So how do we treat this disease and what's on the horizon to improve outcomes in these patients? So traditionally, the treatments that we use in BPDCN have been extrapolated from the way we treat other leukemias. So there's a very common regimen, for instance, called 7+3. This is a chemotherapy regimen that consists of 2 agents, and it's been the standard of care for many leukemia patients for a very long time. And that's a regimen that's still being used in some cases in BPDCN. We also use other regimens, such as this thing called hyper-CVAD or CHOP. These are regimens that are used in lymphomas or lymphoid leukemias, and these have activity in BPDCN. There really is no consensus or standard of care as to which of these treatments is preferable. And that has made it a very difficult disease to study and a difficult disease to treat because it's such a rare disease. We really don't have a very clear algorithm as to how to treat these diseases. However, more recently, in the last 5 or 6 years, this drug called tagraxofusp, or TAG for short, has been approved by the FDA. And this is a targeted therapy that is active in BPDCN and in many places has become the standard of care. We still don't have the kinds of large randomized trials comparing groups of people getting tagraxofusp from comparing them to other people who are getting traditional chemotherapy regimens in order to establish that tagraxofusp is superior, but it does have really notable efficacy both in the front line when people are newly diagnosed and in the relapse setting. So at many academic centers, tagraxofusp is one of the first regimens that we do use in patients. And I'll go into that drug a little bit more detail later. In some patients who have isolated involvement in one area of their body, such as a skin lesion that's very bothersome, and that's the only lesion, a big nodular lesion, we'll sometimes use radiation just to that area to try to kill off the cells there, and sometimes also improve symptoms. Sometimes when there's more than one area, but they're much more defined than some of those other pictures I showed you where there's, diffuse rash all over the torso, we'll still consult with our radiation oncology colleagues and sometimes do radiation. As I mentioned, everybody needs prophylaxis to the central nervous system with those lumbar punctures, and we also treat them with chemotherapy when we do that. And stem cell transplant is a really, really important modality in BPDCN, and it's really the only guarantee for a cure, or likely the only guarantee for a cure in most patients. There are 2 points I want to make here too. Because this is a rare disease, it is really, really important to be treated at an experienced center, a place where they know how to use agents like tagraxofusp, where they've treated patients in the past, and where you can get multidisciplinary care from leukemia doctors, radiation oncologists, and stem cell transplant doctors. It's really crucial. And then the other point I want to make is that clinical trials are always a good option in BPDCN. We know that anytime the treatments that we have at our disposal are insufficient and the outcomes are not where we want them to be, trying to get onto a clinical trial is really, really helpful. We need to learn more about these diseases, and we hope that a lot of our clinical trials will improve the outcomes compared to what our available therapies are.